Good afternoon. Welcome back to Good Samaritan Facebook Live. My name is Dr. Scott Stein. I'm a family physician here in Vincennes, Indiana, and Chief Medical Officer of Good Samaritan Physician Network. Joining me as always, Adam Thacker, who is our Chief Operating Officer of Good Samaritan Hospital. We will be giving you our weekly COVID update, giving you statistics, kind of where we have been over the course of the last few weeks or so, what the status is currently in our community with our local population, also with the hospital, and then a little outlook as to kind of where we are headed over the course of the next few weeks. Certainly the most significant thing, and obviously us ramping back up to going weekly, is there has been a significant change in the number of patients that we're seeing with COVID just over the course of the past 2 to 3 weeks or so. The numbers that we talk about every week are the total number that we've had positive, which is approaching almost 5,000. But the real significant numbers are those positivity rates, which include the all test positivity rate, which is around 23%, and then the unique positivity rate, which really we look at more closely, right, which is over 42%. Throughout the course of what we've done here with this Facebook Live, over the course of the past year and a half or so, we haven't seen any numbers that have approached those, even when we look back into the fall of last year. So really significant. And also, as you were telling me, the numbers looking over the course of the past couple weeks versus a month versus 90 days really tell quite a tale.
Yeah, and as you mentioned, I mean, we're seeing a surge unlike we've seen before. And unfortunately, we didn't think that we would see something like this again, but 4 out of every 10 individuals are testing positive. And then when you look at really the last 30 days, 940 cases, positive cases in the last 30 days, take that out to 90 days and you only add 80 more and get to 1,020. So certainly I've seen things just ramp up at an unprecedented pace, and then that puts pressure on everything else. From a healthcare standpoint, it goes without saying that more positive cases is going to lead to more hospitalization, more illness, because regardless of the virus, if there's more transmission, eventually that catches up to more sickness, hospitalization, more death. It's inevitable as the numbers climb. It still remains very true that the largest percentage of the population can recover at home. Mild to moderate illness. We've got some outpatient therapies that we'll touch on that have been very successful, but it's Russian roulette. We keep this transmission rate up, and the wrong person with a weakened immune system or at risk, and sometimes it's even genetic, and we don't know why they're at risk. There are some cases that just are kind of baffling because they're a young adult, healthy, but have a really hard time, and so that's what leads to pressure in the hospital, a high number, in the 20s in the number of inpatient COVID patients, now seeing some transition to more ICU level patients. We've had ventilator needs, so we're kind of back in that discussion, and it just becomes hard to have the conversation as to, we look at that, but we also look at the very heated, or I guess debated topic, I wouldn't call it heated, debated topic of vaccination versus unvaccination. And regardless of where you get your information, we look at what's happening on the ground, and we know that 92+% here locally of the resources in the hospital, the people needing the most care, are unvaccinated. And so you look at that and say, what can we do about it? And the answer's sitting in front of us. So that's what we can do about it. There's so many other measures, but we see that and see this surge, and I think from a general public standpoint, it doesn't seem as big of an issue as it does at the healthcare standpoint, but we really see a hospital system or a hospital that's being maxed, and the ambulatory system that's being maxed. And we talk to our peers in other communities, and unprecedented, unheard of things in my time as a healthcare leader, I'm sure in your time as a physician, where patients for care that we provide all the time, now because of strains on resources across the board, are looking at having to have that care hours and hours away. Some of the stories they're frightening, and then you look at it and say, but numbers are still climbing. So what's next?
Yeah, and really, many people are asking, why are we having this big surge right now? And one of the things that we know about the current variant that we're dealing with, which is likely Delta, is it's far more contagious, so it's spreading more easily. That's been compounded by the fact that a few sort of events have all come together. Obviously, we've had holidays, we've had schools restarting, and as a result of that, we've seen an increased transmission locally. And just as Adam said, the biggest complication or result of that is that increased spread exposes other people who are at risk. There's absolutely no question that the vaccine is doing what it's supposed to do. And the important thing to keep in mind with that is the vaccine does not necessarily keep you from getting the virus. What the vaccine has been proven to do is it reduces mortality. It reduces the likelihood that you are going to die. And it also reduces the likelihood that you'll have to be admitted to the hospital. And really what we are dealing with here locally, what people are dealing with regionally within our area of the state, and what people are dealing with across the country is a strain on the healthcare system because the hospitals are full. As Adam said, this is something that in 24 years of being a physician, I have not ever seen us get into a circumstance locally, regionally, statewide, within the Midwest and within the nation, where hospitals are just simply full. And they are full of individuals who are sick with COVID, who are not vaccinated. So what the vaccine is doing, hopefully, as we continue to push for people to get updated and get their vaccines, is to reduce that hospitalization rate, reduce that mortality rate, keep people alive and keep them from getting so sick that they have to be hospitalized. So we are still encouraging that. Now, a lot has changed over the course of the past couple weeks as far as some vaccine recommendations. Many people were waiting and holding out for an FDA approval, and just this past week, FDA approval came through. Now I'm going to hand this over to you because perhaps the most difficult thing that we're going to do all day is properly pronounce Pfizer's new vaccine. I'm going to start with Moderna, which is Spikevax. That's easy. And I'm going to hand the other one over to you.
Yeah, which, by the way, Moderna, great job. They take the cake. Spikevax is an awesome name. Pfizer, now FDA approved as of Monday, is Comirnaty. So they combined community, immunity, mRNA, and COVID.
Came up with a horrible word.
Once I heard that, I was like, oh yeah. No, Comirnaty. So you might say, well, we just call it the Pfizer vaccine. Why has it changed? So as drugs go, or vaccines, both follow FDA approval. As they go through the process, they have a technical name, a trial name, research. A lot of times in the drug world is active ingredient, and then they become a brand name. So that's what Spikevax for Moderna will be when approved here very soon, and the Comirnaty is with Pfizer. So that's a big step in approaching vaccine hesitancy, because as we have heard, the emergency use authorization process, because it had the emergency in it. So is this an emergency when it's drug out for as long as it has? It still is. And that EUA process is for being able to respond quickly. So last December, vaccines were given EUA, started administering it. While that was going on, the actual FDA approval process was still happening. And really, something that never happens is because this happened, FDA also looked at, as part of the approval process, that there were over 200 million doses in the United States given. So when you talk about data and review, and you think of clinical trials, which usually have a budget and cost constraints and a few thousand people in it, This one started with 40,000 people in it, which is much larger than any that you usually see. And now it's 200 million doses of the Pfizer vaccine to analyze adverse effects, contraindications, all of those aspects. So from a scrutiny standpoint, I can confidently say that vaccine, drug, whichever you want to look at it from an approval standpoint, this is the most scrutinized FDA approval that we've ever seen in our lifetimes, and hopefully is the most scrutinized that we will ever see. And good news is that those safety efficacy profiles have proven to be outstanding from being able to accomplish what we talk about, prevent hospitalization, prevent death, and it starts with safety. And while there's no such thing as no risk at all, even an injection in the arm of normal saline, it has a risk because you're injecting somebody in the arm. There's risk of a site infection, site injury. Somebody could just have a reaction to the pain of the stick. So there is no such thing as absolutely zero risk, but certainly this profile lends itself to very, very low risk And in the medical world, we talk about risk benefit and one outweighing the other, and it's a landslide. The benefits outweigh the risk.
And the other thing that happened that many people are asking about now is booster of the vaccine. And so what they have found, and again, there are studies that continue to be ongoing in the pediatric population, in other populations with each of the vaccines. But one of the things that continues to be monitored is those individuals who received a vaccine, what happens with their immune status over time? Will they need a booster? What happens if they had COVID, got the vaccination? Those studies are still in the process right now. And what they have determined is that a booster would be beneficial certainly in the populations that have altered immune systems or have more comorbid conditions. Those individuals are eligible to get a booster at any time now, based on the fact that we feel like that is going to help them as this next phase rolls along.
Sure. And as this has been a worldwide pandemic response, we continue to share information. And countries such as Israel started out with giving boosters, saw good results in those populations. And so CDC looked at that, our FDA looked at that and said that would be beneficial in this population. And to kind of understand, okay, why that population, you have to step back and think a little bit about how vaccines work. Is vaccines leverage your antibody response, your immune system. So if you have a moderate to severe weakened immune system, either due to you're on treatment for a disease or you have an immunodeficiency type of disease that you've been diagnosed with, then when you're given the vaccine, your immune system may not create the same response that an otherwise healthy individual would. So that third shot gives a third jump start to your immune system and raises that antibody level. Thus, if you come in contact with the virus, your body can jump in right then and start to fight it. So that's the how and the why. And as we look at that, it's about going back to all the way to the beginning. We know there's certain individuals that are at high risk. Our older population, our immunocompromised, chronic disease, and it's because their immune system and all of those are slower to get that jump start. The virus gets to take over quicker, so that third shot makes sense. And as we roll forward, September 20th is the date that's been outlined from the White House, FDA support under that EUA process. So just as a clarification, full FDA approval of Pfizer is 16 years of age and older. 12 to 15 still being administered. EUA, boosters, EUA. Had the question, well, why one versus the other? Does that mean those aren't safe, so they won't approve it that way? It's all timing. So adults were approved first, 16 and older. That's the data that was submitted. That's FDA approval. The 12 to 15 came later, so now that's being reviewed, expected to be approved, and then again, boosters coming later. But after the 20th, it will start to roll into anybody is eligible for a booster if they've already been vaccinated by Pfizer or Moderna. Johnson & Johnson data, again, its timing is just a later approval, so the timing of that moves back. It doesn't mean that there's anything wrong with that vaccine or anything like that. It's just a timing mechanism. But 8 months after you've already been vaccinated, had that second shot, then you're eligible to get a booster. Right now, I think that's an area that everyone has to kind of look at their risk. The 2 shots are still considered fully vaccinated. You don't have to run out and get a booster, but continue to watch the data, and we look at that and say, are you at risk? Are you in healthcare, which would be a higher risk area? Are you a farmer sitting in the cab of a tractor by yourself a lot of times and you're fully vaccinated? Booster may not make as much sense to just at the 8 month and 1 day mark, I have to get it. It may make sense down the road, but there's a little bit of an assessment of what are your risks for that piece.
And really, this is a discussion you can have with your primary care physician, come up with whether you think are an at-risk person, and then what the timing of that booster would be. Another question that frequently comes up as we relate to immune systems is what about supplements? I get asked every day, should I be taking extra zinc, vitamin D, should I take vitamin C, so forth. For the most part, there's not really much compelling data that says that any of that works. There are all kinds of videos smattered across social media as to the amazing benefits of all these things, but what we have seen is there's not much clinical data to support that. Is it harmful to take those things? Probably not. Extra vitamin C, not harmful. Certainly extra zinc, not harmful. There are some problems associated with excessive amounts of vitamin D, but it's fine to take these things, but unfortunately not the miracle cure that you're being led to believe online. The things that that we really always want to go back to is early identification and testing to decide whether or not you are positive and if you do need a treatment that's proven. One of the things that we've had tremendous success with has been the monoclonal antibody infusion. There's been a little bit of a change coming up on that recently and how that's going to be administered through the course of the past, basically since back in January when we've been administering this. We have seen people turn around very quickly, just within 24 to 48 hours after receiving this IV infusion, which directly goes in and helps to counteract the effects of COVID-19. But the key with that is getting diagnosed early, identified as a candidate, and getting that administered. The majority of the time here in our facility, we are identifying those people and they're getting that administered either the same day or the next day. However, the volume of that has increased tremendously. And so the numbers of that particular treatment that we were administering as recently as a couple weeks ago was maybe 1 or 2 a day, now up to 10 to 19 a day right now. And one of the methods that has changed is how we're going to be administering that. And that is a recent change also.
Right. So as the monoclonal antibody came out, it was IV infusion. So we start an IV, hang a bag, and that's given an infusion over 20, 25 minutes, and then there's an observation period. It is also approved to be given as a subcutaneous injection, which is just below the skin in 4 separate small dose injections, 2.5 mils. So we're transitioning to that. Helps from an efficiency standpoint. We don't have to start an IV. Allows us also, as is becoming more and more apparent, the conservation of resources, whether it be IV tubing, IV filters, all of those aspects play into that. Something that from a general public standpoint you would never know, wouldn't be expected to know, is that when we prepare that medication, we as in the pharmacy team prepares that monoclonal antibody, they use a filter to prepare that to then be given to the patient. That is the same filter that is used for many of our chemotherapy patients in the infusion room. That filter is of short supply, difficult to obtain, so we have to look at how to conserve that so that our active cancer treatment patients can get their cancer treatment timely, efficiently, and the correct way. There are not alternative administration opportunities there. So as we're moving to that subcutaneous, that will be, we started that today. First few patients, everything was fine. It was just a change for staff, but there's really been no issues. Same efficacy, we expect the same results. There are other hospitals that we've talked to that have been doing this for a few weeks now and have had really good results. So expect to continue to see that. And with the monoclonal antibody, no different than we talked about with hospitalization. As the number of cases increase, the number of individuals that are appropriate for that and we can keep them out of the hospital is going to increase. So as that number continues to climb, the sub-Q injection, not starting an IV and hanging it and all of that, allows us to be more efficient and take care of more individuals. And that's why we're here, is to be able to respond to what our community needs. And timing is really important with that medication and that treatment with the antibody therapy, because if we wait a couple days and somebody gets sicker and sicker and end up needing oxygen or needing hospitalized, then they're no longer a candidate to get that. So once they test positive, have symptoms, know they're at risk, we really want to be able to give it within, same day, next day, 2 days max.
And part of that process also should be to be evaluated. One of the things that's really important is to identify those patients early on, identify which ones are candidates and would best benefit from that, and then also make sure that they're not too sick. What we mean by that is the monoclonal antibody infusion has been proven to be tremendously effective in reversing the course of the illness early in the disease process. Once patients have pneumonia, once they are hypoxic, meaning their oxygen levels are low, not shown to be effective at all. And so it's identifying those patients early on. The wonderful thing now, if we rewind the clock an entire year, is we had big challenges with getting people tested. Testing is widely available now. Testing is available at our community care clinic, at MCV test site as well. We're going to be moving the Williams Brothers site as well. It's also available to be tested at kits that you can get at the pharmacies now. Those are a bit in short supply, as you can imagine, but the benefit is that test, that rapid antigen test, is the same test that we are using at our facility. So it's well proven, it's very effective if you have symptoms. So one of the things that's important that I want to touch on today is we have seen a flood of patients over the course of the past couple weeks or so that are coming in to be tested. And a large percentage of those patients have just been exposed and are wanting to be tested asymptomatic. We are absolutely discouraging that at this time. for a couple of reasons. Number one, it is not going to change the course of what we do with patients at this point in time from a clinical standpoint. Number two, it is consuming resources that we really need for other patients that potentially are going to be sick. And the likelihood of that test being positive is significantly lower, meaning the sensitivity of that test is not nearly as good. So although the FDA has said that that's something that can be done and the testing can be performed, we would really prefer that patients pay attention to their symptoms and wait until they have symptoms to be tested, rather than being exposed to somebody and then rushing them to get tested, because it gives people somewhat of a false sense of security that you had COVID, I was exposed to you, I'd like to go in and get a test done right now that shows that I'm negative. That accomplishes absolutely nothing.
Yeah, and as we look at that and knowing our transmission rate, it does more harm than good, because that false sense of security, you now have a negative test, you say, I can go eat lunch wherever I want, I can go back to work, I hang out, go to that party, whatever the case may be, and then 48, 72 hours later, oh, I have symptoms now. And so the timing of testing, you hear a lot about false negatives, and and the test, I was positive and the test was wrong, I was negative. False negatives, there's a little bit of a misnomer there because you believe the test was wrong. The timing of the test was wrong. The test will only tell you if the virus is present, if it's present. If you test too early, as Dr. Stein was mentioning, if the exposure was today and you come and get tested today, we should just have a little bucket where you can drop some money for us to tell you you're negative, because if you're testing right after exposure, you're going to be negative. You have to have the time for that to be a detectable occurrence, and that is day 5 from exposure is the ideal, or beginning of any symptoms. Of course, we would test. And then the other piece of this that we're seeing at our convenient cares, and our convenient cares are doing a great community service, but the volumes are something we've never seen. And
unbelievable.
7-8 times what we typically see. And so we're staffing to that, but we also have to have appropriate use of medical supplies of our medical team. So if you get a negative test, you won't be retested for 72 hours. And that's not just to deter people. That is also science-based, that if we're testing you shouldn't just be retested every day. I know we've had some of those occurrences. I'm going to test Monday, Tuesday, Wednesday, Thursday, and then I'm positive. Well, we're going to test you on Thursday, or if symptoms occur. But our team out there, and you've worked out there, can help to educate anybody that comes out there with questions. We're going to ask about when your exposure was. Do you have any symptoms? A little bit about what the exposure was. And then we're going to look and see, have you been tested? And if you were tested yesterday, absent some clinical judgment from a provider that says something's materially different, we're not going to test for surveillance or curiosity.
Right. The other thing that's important to realize is the same things are happening this time of year that happen every year. When we look at school going back into session, what obviously happens is everybody goes back into session and everybody spreads their bugs around. This is normal. This occurs every year. Usually 2 weeks after school starts, we see that happening, and that's happening again this year. So when patients have upper respiratory viruses other than COVID, RSV, allergy problems, things like that, the symptoms have a lot of overlap. But it's important to realize if you find out that you are negative, if you get evaluated by a provider or you treat appropriately, you don't have to quarantine for those issues. So there's a lot of confusion right now in quarantining for RSV or quarantining for upper respiratory infections and so forth, or isolating for those if you've been diagnosed. And the fact of the matter is you don't need to do that. There's a lot of confusion also going around because each of the schools have come up with some different guidelines with regards to what they want to do with students as it pertains to masking, as it pertains to if you've been vaccinated, what your precautions are, and then if you are positive, how long you isolate for, and then what people around you have to do as far as quarantine. So it's important to make sure that you are in tune with your child's school, their administration, and what their plans are for that. Each one has a little bit of a different approach, but it's important to realize that the goal is to keep our kids in school and keep them safe. The glorious thing that we have seen, thankfully, is very, very few kids are getting terribly ill with this illness and having to be hospitalized. That being said, they are also the vectors for this illness that helps to spread it around to parents, grandparents, everybody that's in contact with that child within the family. So it's important to realize that although they are not getting terribly ill, that they can easily spread that around to other individuals.
And as a word of caution on the pediatric side, been very fortunate in what we've seen here, but national landscape many commentaries from larger cities, larger systems about pediatric ICUs. I'm seeing a census peak up and even some of them being full. And even here locally, while the total number has been very low, we have had some sick pediatric individuals that have needed care, to be sent somewhere for care, or have needed a hospitalized level of care. And it just takes one occurrence for that to be obviously life-changing. And how sick does somebody have to get before we realize that there are ways to affect this and prevent this? And as we talk about the other viruses, I hear the comment from some of, with other viruses we let it run its course and we don't do all this, so why don't we do that in this case? 20 plus patients in the hospital right now due to COVID, and 90+% unvaccinated. So, I put the plug in again. I know I'm broken record, but if everybody wants to return to normal and we want to be able to just go about, there's a seasonality to COVID like there is influenza, then 90+% get vaccinated, and guess what? We can handle the 1 or 2 or 3 that have a breakthrough infection that need hospitalization, rather than the 20 plus that becomes 30 plus that becomes something that we can't handle. So it's not just a numbers game. These are individuals that are impacted, but there's a way to return to normal, and for some reason we're just kind of walking right past it.
Yeah. I think choice, freedom, liberty, all those types of things come into this discussion, and we're not going to get too much into the weeds arguing on that. But the choice to get vaccinated is not just about yourself. It's not just about protecting yourself. Certainly it is if you have medical problems and comorbid conditions, but what we are talking about is how that affects all the people around you, the people in your household, the people in your community, your grandmother who is on chemotherapy, your cousin who has an autoimmune disease like rheumatoid arthritis and takes immune suppressants. All these types of things play into that, and that's why this is so important. So when people feel the pressure that they are being forced into something that they don't want to do, no different than wearing a seatbelt, not smoking around other individuals, having to get hepatitis B vaccine before you come to work just like we did, just like teachers do. This is not just about you, the individual. This is about who you are serving, who you are around, and who you are beholden to keep them safe. And so that's really what the discussion that we're talking about today. And when Adam gives you the statistics as we talk about what's happening at the hospital and these unprecedented numbers and the hospital being full, that's the challenges that we're facing. We are trying to provide these services to not just the people who are sick with COVID, but the people who are in our hospitals every day for a whole variety of other reasons. And those individuals are suffering now as a result of a lack of services and difficulty in delivering that care just simply because of these numbers. So that is why we are asking people, please, don't believe what you see on the tabloids. Don't believe what you see on crazy person on social media. It's important to get your medical information from reliable sources. And those decisions that you make absolutely have an impact on everyone else.
Yeah. And the reliable source piece you mentioned at the end, I think we would always welcome somebody fact-checking us or asking why we're a reliable source, and feel like we do our research on science-based information. But if there is a question, then certainly can submit that. We don't compare our medical information from the reputable resources and science-based to what is just a commentary on Facebook or a document that's not rooted in science. But we'll absolutely have the conversation of why should I get vaccinated, or why should I wear a mask, and public health initiatives versus personal choice, and why one trumps the other. And personal choice that only impacts you as an individual is your choice. Yep. But when it starts to impact others, that leaves being a just sole choice and becomes a public health aspect. Unfortunately, that is how it works. This is extremely transmissible, and you can impact others by your choices.
Absolutely. Any other things discussed before we go to comments or questions?
I think from a screening visitation standpoint, just an update, we continue. That's a fluid document. We turn red in our county today based off the numbers that were presented. That's not a surprise. So we'll continue to look at that. But right now, 2 visitors are allowed with inpatients. 1 visitor for outpatient areas only if deemed necessary for decision making or mobility of the patient. Otherwise, no visitors. That's across ambulatory offices, that's in the hospital and outpatient areas. And then starting this week, we also are back to screening. So when you come in, you'll be asked questions. We won't be actively taking temperatures. That is kind of fell to the side of being a real quick determining factor. But we are asking about COVID symptoms, about COVID exposures, and then being approved to be in the hospital. So expect to see that. And just as a FYI, why is Good Samaritan doing that? That is a federal statute that was put into place. So you won't walk into a hospital that is not doing that. That I guess is federally compliant. You might walk into one that's not doing it, but it is a federal law that was signed in through the White House. So all hospitals will be screening, and you'll see more plexiglass because there's more barriers to protect everyone. We know that's a change, but they're called temporary standards. I don't know that they're going to be temporary. We should just assume that there's going to be some changes in healthcare indefinitely with potential exposure risk.
Tiffany?
There are a couple of questions about the vaccine requirement for employees. One of those is, will the patients have a right to say whether or not that they do not want a vaccinated employee taking care of them?
Sure. So just so everybody's on the same baseline, we did put into place that all Good Samaritan employees, students, vendors, business partners that are coming in Good Samaritan, providing care to our patients, interacting with each other, are required to be vaccinated with one of the 3 approved COVID vaccines by November 1st. We were pending that date based off FDA approval. Now that has occurred. November 1st is now the date. Some questions that have been coming up, not unique to Good Samaritan, but from patients, is how can I assure that I'm coming in for something not COVID related, that my care team is vaccinated, is providing the safest care. So we're talking through how that will work. I certainly understand. I think it's a fair question from a patient standpoint to know, how can I be safe in the hospital? I think what I'll tell you right now is that we wear masks, and in patient care areas, N95 mask, and patients wear masks. Our hand hygiene protocols are, above and beyond what you would expect anywhere outside of healthcare. There are barriers in place where they need to be from an interaction standpoint, and then come November 1st, that requirement is in place. And then after November 1st, if we have individuals that are unvaccinated, we'll continue to look at additional safety measures that need to be put into place to assure that we're able to say this is one of the safest hospitals in the country. And so we'll continue to work through that. From a patient assurance standpoint, that's, I think, what we can provide right now, that we are continuing to see our staff become vaccinated. Over half already are now, and continuing. That will obviously ramp up exponentially between now and November 1st. But all of those other safety measures also reduce transmission of the COVID virus. They're not a replacement for the vaccine, but they help to mitigate. Because like masking, we know that when universal masking, which is in place in healthcare, everybody wears a mask, especially in patient care areas, that's 99% effective. Now, when we have optional masking, and some do, some don't, that falls way off. It's kind of futile to even go that route. But when we have mandatory masking, as we do in the hospital, then we then we can really see the evidence-based data that says you're decreasing transmission, so our patients are safe. And my last plug on that is been involved with pretty much every COVID positive patient in the hospital in some way, shape, or form, and many of the employees and such. I'm not aware of any patient coming here for any service that has gotten COVID from an employee, from a visitor, that transmission has happened here at Good Samaritan. And that's because all of the safety aspects that we put in place.
And regarding the requirement for employees to be vaccinated, someone asked, how are we addressing those employees that refuse?
So part of it is just simply that some of those people were holding out for FDA approval. Thankfully, now that that's been crossed off the list, they have options that potentially they will feel more comfortable with. And the other part is just simply education. Part of what we're doing with everybody right now is to understand what the vaccine does, what we expect out of it, and then also to understand that this is just part of the requirement of what we do as healthcare providers. As I said, Adam and I both had to have hepatitis B vaccination and tetanus vaccination 5 years ago, 2 years ago, 3 years ago to be employed with Good Samaritan. No different than if you're going to be a teacher, no different if you're going to work in the food service. All of these things are part of the requirements of when we provide care to people. So part of it is just helping educate people that that is just the normal process and that it is safe. You know, we've done 56,000 vaccines or something crazy like that. The number of vaccines that we have given is tremendous, and the effect that it has had in prevention has been tremendous. And the remarkable thing is we've seen very little, if not hardly any, side effects other than the usual stuff we would think of, which is injection site pain and discomfort, low-grade symptoms over the course of the next few days, occasional vasovagal symptoms. But these are the typical things that we see with all vaccinations. So there's nothing crazy about the vaccine. There's nothing absurd about the method of how it works. In fact, I think what we all believe is many vaccines are going to be converting over to this type of technology over the next few years simply because this vaccine has shown lower rates of all the things that people worry about in terms of allergic reactions, hardly any allergic reactions with this type of vaccine, no egg allergy or protein allergy issues with this type of vaccine. So many less side effects and consequences, even the neurological symptoms and things like that. Guillain-Barré, other types of neurological problems, we see lower rates with this vaccine than we've seen with all of the traditional vaccines that we got when we were kids, that our kids have received whenever they went into preschool and got boosted at 11 to 12 years old. Lower rates with the COVID vaccines than with those traditional vaccines.
When you look at adverse effects, keeping in mind that people report tiredness, mild fever, and that goes into that profile that says this percentage had an adverse effect. But when in reality, if we could drill it down to just some tiredness and a mild fever, we'd want that to be 100%.
Yes.
Because it shows that your immune system is responding to the vaccine to create that protection. So there should be some response. If you don't have any response whatsoever, there's kind of that question of how much a response did I get, didn't get. So I always want there to be a little bit of a, hey, I felt a little tiredness that evening. That's a good thing. My body's kicking into overdrive.
And someone asked about after getting their second shot, how long is it until they're fully protected?
14 days.
And the rapid test, are those testing for all the different variants? So whatever
Yes.
variant it is, they're going to be
So
negative or positive?
the rapid test is an antigen test. And we have, I worked at our community care clinic last week, and I had a lot of people asking me, are you checking for the Delta variant? And the answer is yes, we are checking for the antigen, which is the particles of the actual virus. And that test doesn't care what the variant is. And quite honestly, the determining which variant doesn't change anything that we do clinically. The only reason that that's important is from an epidemiology standpoint. They want to know basically where that variant is and what's happening. So samples have been sent off by Dr. Stewart in the health department to help determine that. But it really doesn't change anything clinically about what's going on. We know based on where the Delta variant was and where we are now, that's what's happening. The antigen tests that we use are highly effective, especially if you're symptomatic. The other thing to keep in mind is the tests that are available over the counter. The card that we use out of community care and the card that you get at the pharmacy are exactly the same test. There is no difference. The difference is how that's administered. So one key thing to keep in mind is the people who are doing 200 to 300 swab tests per day out of community care, they're pretty good at it and very effective in collecting that antigen. And so I know personally with some of my patients who have done the test at home that kind of dabble on the outside of the nose and a little bit on the inside are probably not getting a very good sample. So although the test is very effective, it's important to realize there is a very important methodology as to how that test is collected. We train all of our individuals, all of our staff into how to appropriately administer that test. And that's why we get good results out of it. So yes, the tests are exactly the same, but it's very important that it's administered appropriately.
And the result, we test for all variants, but the result is positive, negative. We
Yep.
can't tell you Delta, Alpha, Beta. It is positive, negative.
And clinically, one thing that I can tell you, and all the people who work in the testing facilities can tell you, is when we see people that come in that we are highly suspicious that they are going to be positive, that test is positive nearly instantaneously. The test results come back within about 15 minutes or so, but we can tell you that from a clinical standpoint, when you have a large antigenic load, a large viral load in your system, and you are tested, by the time we stick the swab in there with the fluid in and it passes up, it is instantaneously positive. So that's why we go back to the please don't come and get tested if you are asymptomatic. The test is not going to pick it up if there's not enough substance there to be tested. But if you're symptomatic, please come in, get tested, get evaluated, because we want to help advise you as to what to do next, and also see if you're a candidate for somebody that should be treated with monoclonal antibody.
Do you recommend using ivermectin to treat coronavirus?
You want me to say
Well,
that,
I'll hit it and you can hit it too.
Okay.
So the most important thing to keep in mind is there have been lots of studies done on this drug. And a lot of the studies and how those studies were done and where those studies were done are not reliable data. So right now, that is definitely not mainstream, despite what you may see on social media, despite all of the proclamations and declarations and school board rants that you may have checked in on. That is not a treatment that we are using on a routine basis because it's simply not proven to be effective. Hydroxychloroquine, ivermectin, the high doses of zinc, the high doses of all types of vitamins really have not been proven. And part of the thing that's difficult is knowing where that data came from. And some of the countries where that initial information was born out of, which was some of the South American countries, it has been determined later on that that information was falsified. And unfortunately, we are at the mercy of knowing where those sources are. And the thing that you have to take solace in, and this is something I would caution everybody with, is think about the source where you're getting the information from. I realize that politics and medicine have gotten into bed together, and that is an absolute mess. But if you look at reliable sources, Mayo Clinic, Cleveland Clinic, all of those places that are outside of the FDA and NIH and the World Health Care Organization, what we look at, what Adam and I look at, what all of us look at clinically is outcomes-based data, and that's what matters to us. You can proclaim all kinds of things, but what we want to say and what we want to get through to everybody is what we see when patients are treated with reliable, proven drugs, when they are treated with reliable, proven therapies, what the outcomes are. And we see that here at our hospital every day. We have seen that with the monoclonal antibody therapy and what tremendous improvements we've seen in people turning around quickly with that. One of the biggest rants that I have gotten forwarded to me over and over and over and over with the school board individual, not mentioning any names, that gentleman said that he had treated 15 patients for COVID and they had all had these wonderful outcomes. I treated 15 patients with COVID Friday afternoon, okay? Half of a day in convenient care clinic. So check your sources. Please get your medical information from reliable sources that you know and that you trust.
I think the only thing that I would add is we in both of our training, pharmacist, physician, and all pharmacists, physicians, and many other professionals, we take the Hippocratic Oath when we finish schooling, and I certainly can't quote it all, never could. But the gist of it is first do no harm. And so when we talk about giving a medication that is not FDA approved, and yes, physicians use medications off-label FDA when there's data to support that and they feel confident in that, but that's under the supervision of a physician. And so as we talk about ivermectin, and there's been some touted success in early prevention of hospitalization, there are not randomized controlled studies to say a placebo group in the same time frame, your immune system, you may have just got better, but we added a drug that we may not have even needed, and it has led to some side effects of seizures and some pretty significant concerns, because we're talking about a drug. We're not talking about a benign agent. And I'll be the first to say that because we very diligently follow the science, the FDA, the CDC, that if the FDA comes out and there's enough data that they make a recommendation that ivermectin should be part of treatment of COVID for inpatients or outpatients, then we'll support that after we look at the data and are able to do that. But right now, the FDA statement that was made late last week was, you're not a horse, stop taking veterinary medications. And so I'm sure there are some that don't trust the FDA because it's a federal entity, but they've approved every drug you've ever taken, from ibuprofen for a headache or swelling to your blood pressure medication to your diabetes medication, and that there's a built-in process fail-safe for that. And when we don't follow that, there are unintended outcomes and consequences of doing such. So I think that's the risk reward is where it's been touted as successful. There's no trials to say, that's an outpatient setting where they could have gotten better on their own. There is some inpatient use, and full disclosure, we have used it some at Good Samaritan under the guise of infectious disease physicians, pulmonary critical care physicians, hospitalist physicians, pharmacists, consulting on what should we do with that patient, and used in a controlled setting where it could do no harm, but we're at a point that we're looking for something to help. It should not be used, if you have livestock and have ivermectin as anti-parasitic, it should not be used based off Google dosing. That's our key message, is that should only be used in a controlled setting, and when we have a study data that says, hey, this is where it's safe, this is where it's not.
Yep. 1 dose required for worming, by the way, just in case you want.
More vaccine questions. One you talked about a little bit ago, the Johnson & Johnson, what if they don't have a booster? What does that mean?
Well, I think the data still remains to tell us. So right now, the projections, if you will, are that there will be a booster. J&J has said they are working on that, but the data wasn't submitted to, or hasn't been submitted to the FDA for that emergency use authorization to be expanded to allow for boosters. So that's expected. At some point, if it comes back to say that we're not, then I assume that there will be additional recommendations, which really come down to 2 things. Either the recommendation is the antibody production from that vaccine is holding steady, so there's not a booster needed, because that's what the booster does, is it jumps our antibody protection back up, or the recommendation will be a booster is needed, but it will be with the mRNA vaccine of Pfizer or Moderna. Right now, those are not recommendations. That's just here's what can happen. One of those 3. Johnson & Johnson booster is approved, no booster is approved, or the booster is approved but change vaccines.
Yeah, and one of the things that we continue to have on our side, even when we went back to May, June of last year, is time. As time is passing, all of this research is being done. All of these studies are being done. More data is coming in. And so we are learning more about what if you had COVID and then got the vaccine? What's your immune status? What if you got vaccinated 7 or 8 months later, got COVID, the new variant? What's your immune system like then? What's your immunity? So all of that stuff continues to come in, and thankfully all of that research is being done on an ongoing basis. So we will know more as each month passes by to determine who needs boosters, what target population is best, what if you had this one versus that one.
So there are several questions about religious exemptions, like what actually qualifies an employee to have a religious exemption?
So as part of statute from Indiana law, when employers mandate vaccination, which is covered by equal employment opportunity, that is allowed, Indiana state law, but there does have to be the provision of a bona fide religious exemption or a medical exemption. We've talked in detail about the medical side. On the religious exemption, we have a exemption form for Good Samaritan. All hospitals do. Probably already had one in place from other vaccines, but have adapted that for COVID. That has to be completed, and basically it is signed by a member of clergy that has had a discussion with the individual about the risk benefits of the vaccine and talks about the production, and then it goes into why there would be a religious exemption and what that ties to. What we don't do is we're not doing investigative work into can you quote scripture that is your religion, or do you have a authenticated attestation from the Pope. We don't do those things. We follow the same process that we follow for influenza as far as the exemption. And then that's reviewed by our team, Dr. Stein, myself, our employee health, if it ties to a specific concern with a physician specialty, we may ask that specialty. We pull in medical leaders as necessary if we need to look at that. And then ultimately, we have an ethics committee if we needed to look at it from that standpoint. But that's the review process and how that works. And really what it comes down to is a bona fide religious exemption. Employers have a lot of subjectivity in that and how they apply that. I mean, I know of one health system in Indiana. They have a committee that somebody submits an exemption. They have to actually go talk to that committee about why they have a religious exemption. Our process is not that. Now, if there becomes abuse of that system and feel like that's moving in a direction that our unvaccinated population will be of concern for us providing the safest possible care here for patients at Good Samaritan, then we'll address that, because that is the top priority. That remains the top priority, and we feel strongly and firmly that highly vaccinated percentage of our staff help us to accomplish that.
And I can tell you that as of 2 years ago, the number of people that were interested in a religious exemption was microscopic. So we would expect that to remain the same today.
Someone asked about your opinion of Novavax.
So Novavax was one of the vaccines that was in trial. Those trials halted, so it's delayed. To my knowledge, they have not submitted for FDA approval in the United States or emergency use. So in essence, the answer to that is that they would be a fourth vaccine. To be honest, I haven't studied what their pros, cons versus the 3 vaccines that we have available are. And in no way biased towards those 3, but the 3 vaccines that we have are exceptional. I mean, their efficacy data, their safety data are exceptional, and they're saving lives. So a fourth vaccine that can do the same thing, sure. I mean, that adds supply, that adds an ability to get vaccinated, and that may be a direction that goes through FDA. But until that comes out of trial and there's an FDA approval that says that can be used in the United States, we haven't looked at it closely.
Someone asked about long-term effects of the vaccine. Like, how could we know those if it's just been created?
Sure, and part of the challenge, of course, is that with all of the vaccines that we have, we know how things work, we know how the immune system responds. There's not necessarily an answer right now in 1 year, 2 years, 5 years, 10 years, but what we know from our previous experience with the way that technology works, with the way that vaccines work, is if we look throughout the course of all the vaccines that all of our children get right now, there are very few long-term effects that have ever been noted with any of that. Once we get past the Dr. Wakefields and the MMR causing autism and stuff and all the ridiculous false data that came out of those, the vaccines that we have are extremely safe and thankfully have nearly eradicated some of the worst diseases that we have ever seen in the world. And I think that's an important thing. One of the things that I have every day in my clinic is patients who are coming in their 60s, 70s, and 80s, and they comment on why people aren't on board with these vaccines. And it's because those patients lived through the polio eras and the pertussis eras and the diphtheria eras. They have been privy to that. So this is nothing new or shocking to them at all. In fact, all of those people cannot fathom why the rest of the population isn't on board with this. So I get it. Fear-mongering, social media, false information, all of this stuff is hard for people to digest. But again, I would just go back to check your sources. You don't take grocery store tabloids seriously. Don't take rants on social media seriously, because the source is completely unknown to you.
Okay, one last question and we'll wrap up. Someone asked if they recently had COVID. When should they get the vaccine? Do they have to wait?
So the recommendation is once out of isolation and symptoms resolve, that you can get vaccinated. So if you COVID positive, you're going to be isolated. After that 10-day from test or start of symptoms, you're able to be vaccinated. Now, I would suggest a return to baseline from symptoms, because it is, as we talked about, the vaccine will tax your immune system because it's going to create a response. So if you wanted to wait a little bit longer, but as soon as out of isolation, you can get vaccinated.
Yep.
Okay, that's it.
All right. Thank you all for joining us. Again, we'll field questions online afterwards. And just a shout out to all of the members of our staff, all of our nurses, all of our providers, all the ancillary staff in the hospital. Thanks to all of them for all the hard work that they are doing. There are not very many people that can fathom taking their job and multiplying that times 5 and having to do that any given day, let alone doing that on an ongoing basis. And that's really what our folks are doing right now. So we want to thank all those people for all the hard work that they are doing. Our patients appreciate it. Certainly we, from an administrative standpoint, appreciate it. So thank you all for all of your work. And we'll see you again next week.